Dear moderator, dear friends, good morning. Do you have a voice, please? Okay. This lesson will be about certain tips of phacoemulsification in particular situation. One of them is high myopia, and the second is posterior cataract, with two more difficult cases to deal with and facing in our life. Mostly this lesson intended for non-skilled or intermediate skilled phaco surgeons. Starting with high myopia, we all know that high myopia bear a risk of retinal detachment post-cataract. And as well, because of the deep anterior chamber configuration, when we do phacoemulsification over deep in the anterior chamber, this inflicts a pain to the patient eye, making the patient uncomfortable, and this is further making the surgery difficult and make things more complicated. So the suggestions for doing phacoemulsification in high myopia with cataract is a prompt sedation and analgesia to the patient. Keep bottle high as much low as possible, preferable to do 20 centimeter. Don't use lower aspiration. Keep the aspiration as usual because you don't want to end up with a surge. Avoid anterior chamber surgery when changing hands or instruments. And argon laser preferable to be done before the surgery. And if it's not possible because of the cataract, preferably use after surgery as soon as possible. This is the patient who had presented to me with high myopia and cataract, and show you the steps, safer way to do a surgery. When you fill up the anterior chamber with viscoelastics, try to avoid overfilling because again, deep in the anterior chamber making the patient uncomfortable. Normal capsule rexes as usual. No remarkable lining here. Hydrodissection gently should be done. Do not use force or over hydrodissection. Again, we make everything, we try our best to not over deepening the anterior chamber or overinflate the anterior chamber. Keep the bottle high low. This makes the patient more comfortable, just sustaining the anterior chamber stability. Phacoemulsification or phaco as your preference and preference of the grade of the cataract. Here comes the tricky part. When you finish with the phaco and you want to do aspiration irrigation, before removing the handpiece, you need to fill up the anterior chamber with viscoelastics. This will help to not fluctuate in the anterior chamber. Any fluctuation in the anterior chamber will pull on the vitreous body, which in turn pull on the retina and increase risk for retinal detachment. The same thing when you finish with the aspiration irrigation and wanted to implant in IOL, before removing the irrigation port, you need to inject a viscoelastic again and form the anterior chamber and avoiding any fluctuations. Finish of the surgery when implanting the IOL. The second part of the tips is how to do phacoemulsification in posterior cataract, and we know that this is one of the nightmare we face in our life. It's one of the most difficult surgeries. It carries high risk of retinal posterior capsular rupture and high risk of nucleus drops. So points or suggestions to do risk or minimizing these risks are to do a small capsular excess, avoiding hydrodissection but using hydrodelineation, bottle height below the average, and use low flow rate and low vacuum rate. This will not cause any pressure on the posterior capsule. There are many ways have been used before and reported back. The layer by layer technique, the reverse blue technique, but what I'm interested here now is I want to explain how to use a cortex rotation technique, which is a technique I developed myself. This is a grade 2 posterior cataract. We know that posterior grade 2 usually associated with the posterior subcapsular. Small capsule rexes of 5 or 5.5 millimeters. Hydrodissection avoided, but hydrodelineation with a single ring is enough. Yeah. Using vacuum, low vacuum 200 and low aspiration rate, this will reduce the pressure on the posterior capsule and minimize risk of posterior rupture. Phaco is usually enough to finish out the surgery because we are dealing with a soft cataract. Here comes the tricky part. In the cortex rotation technique, you don't eat up the cortex at all. You're just detaching in 360 degree all around from the capsule, just detaching it without eating. I never go to this danger zone area. I never detach this part, leaving to the last. After finishing detaching all the cortex from the 360 capsule, we start rotating all the capsule in one piece inside the back in a clockwise or anti-clockwise rotation. You need to be patient, never hurry up doing this surgery. Take your time, 5 minutes, 10 minutes, never mind. Now it will start to rotate. Yup, it's rotating now. Just want to be sure more, rotating further. Okay, whenever it's rotated, that means the posterior cataract has been safely touched on the posterior capsule. Finishing up the aspiration ligation and safely implanting the IOL. Thank you for listening. I hope I added something to your knowledge.